I did attempt to, but more left to right, if memory serves me correct, or is that the right here? We shall see. And the reason for that is the Jobson horn, the width of it is about 2.5 up to 3 mil. There's different types available. But the ear canal width in this patient's ear is below that, so it's a squeeze to get in. You can get it in probably more vertical, so against the left and right side of the ear canal walls, but not over the top, which is what or at the bottom, which is ideally what we want to do here. So we are making progress. We're bringing this to the entrance. So this is on the left-hand side there, the flesh there, that's the first bend. So we're about 0.5 centimetre now from the entrance of the ear canal. So we have brought it forwards. And the secret is it's just detach that white matrix of skin. You can see that's wrapped around this plug, because that is still also attached to the ear canal wall. Think about that envelope skin, that white skin that you saw, that glossy peripheral matrix of dead skin, as double-sided sticky tape. Not only does it adhere itself to the skin plug, but also to the canal wall. And now we've managed to get the hook in just a bit further over the top, and we've just brought that out. And if you wait till the end of the video, you'll see a still image of this. So we're going into the ear, quite a narrow ear, hairy ear as well at the entrance. And that's the patient's eardrum. They've got quite an inclined ear canal as well. So all of our ear canals, there is an upward slope, and on average 32 degrees, but there's a big range in that. However, I would say this patient's ear canal angles upwards are significantly more than 32 degrees, probably 40, 42. So when we go into the ear, you got to be careful. We just don't pop into the ear. You've got to angle the endoscope upwards. You almost have to coxurus backwards. So you can see how narrow that ear is. You can see all those hairs there, going through the hairs, angling the endoscope upwards to view the eardrum. And so the left is clear. Now this is the right. You can see there's a lot more dry skin here, like an eczema at the entrance. This is a really dry plug of skin, and that's why it's reflective. It's just shining back at us. So I've just started off with the hook, trying to get in behind, trying to break this up. So recommended the patient in their left ear just to use some acetic acid spray, because they've been using the hydrogen peroxide drops. The pH levels neutralised, so we want to re-acidify the ear, and that's what acetic acid is. It's essentially a white vinegar, and you can get it in special formats for the ear, so a spray applicator, and the acidity in the acetic acid will just re-acidify the ear, make it more acidic, so to prevent harmful growth of bacteria and fungi in the ear. On this outside part of this ear, they've just recommended some over-the-counter hydrocortisone cream, just at the entrance, not into the ear, just on the cavern concha region. The inside of the ear is not bad on this side, it's just more on the outer, the bowl of the ear there, you can see. So just put some drops in here just to lubricate the canal wall, because this skin is quite tightly adhered. Just bringing it forwards. When you've got a dry plug of skin, it's sometimes harder to get a suction grip because the surface of the plug is quite rough. It's like sandpaper. So it's harder to get a suction grip. And in addition, when it's rough like that, as you're bringing it forwards, the surface of the skin plug, it's abrasing against the canal wall. So it can be a bit uncomfortable for the patient. It's just essentially like having sandpaper in your ear and someone's rubbing it. So the oil just helps to lubricate it all.